Welcome to my lecture of endocrine pathology. Today we discuss about the diabetes mellitus. So, outline of the topic diabetes mellitus. I have divided diabetes mellitus in two lectures. So, in lecture we discuss about the definition of diabetes mellitus, pathophysiology of diabetes. It includes the action of insulin, glucagon, and how the insulin affect our body metabolism, pathogenesis of diabetes, various morphological and clinical features, diagnosis of diabetes, and the complication of diabetes mellitus. So, insulin is secreted by the pancreas. So, pancreas contain the islet cells of Langerhans. So, the cells secrete the insulin. Exocrine and endocrine cells contain the. This is the cross section of the pancreas. It contains the exocrine acini and the endocrine cells. The endocrine cells is called the islet cells of the Langerhans, which is located in the tail of pancreas. The beta cells which secretes the insulin, while alpha cells secretes the glucagon, and delta cells secrete the somatostatin. So pancreas is composed of the glands which contain exocrine and endocrine component, islet of Langerhans constituting about 1 to 2% of the pancreatic tissue, and it mainly concentrated on the tail of pancreas. So beta cells which secretes the insulin. So this is the immunohistochemistry of the islet cells of the pancreas. Alpha cells which secretes the glucagon. Function of the glucagon is to lower the blood glucose. Function of the glucagon is the glycolysis in hepatocytes and gluconeogenesis. So the hyperglycemia, it inhibits the release of the glucagon hormone. So this is the very important features. Hyperglycemia that inhibit the release of the glucagon hormone, while the low blood glucose, it stimulates the release of the glucagon. So whenever there is a hypoglycemia, there is a increased stimulation to release the glucagon hormone. So in contrast to the glucagon, insulin which is secreted by the beta cells of the pancreas, it contains the higher blood glucose, stimulate the release of the insulin. So whenever in our body there is a hyperglycemia, so blood glucose level increase, that itself it stimulates the release of the insulin from the beta cells of the pancreas. Function of the insulin is largely considered as an anabolic hormone, so it facilitated diffusion of glucose into the cells. So it speed up the conversion of the glucose into the glycogen for storage in liver and muscle. It increase uptake of the amino acid and increase protein synthesis. It speeds the lipogenesis. So basically insulin is an anabolic hormone, so it promotes lipogenesis, it increase protein synthesis, it promote conversion of the glucose into the glycogen for storage into the liver and muscle, while insulin slows glycogenolysis and gluconeogenesis. So insulin inhibit the glycogenolysis, so it prevents the breakdown of the glycogen in liver. It promote more and more storage of the glycogen in liver, while it inhibit the glycogenolysis. So the hypoglycemia which inhibit the release of the insulin, while the insulin, that main action of the insulin is to decrease the blood glucose level. So whenever there is insulin is released from the beta cells, it causes the glucose to enter inside the cells, whether it is the liver cells, muscle cells. So the blood glucose level of our body will reduce. While the delta cells of the pancreas, it secretes somatostatin hormone and it inhibits the release of the insulin by pancreas. Here we discuss briefly about the insulin and action of the insulin in various metabolic pathway. First of all, insulin is synthesized by the beta cells of the pancreas in the inactive form pre-proinsulin. Then it is transferred to Golgi apparatus where it is cleaved into the insulin and the C-peptide. So the pre-proinsulin cleaved into the insulin and C-peptide. So C-peptide levels are marker of endogenous synthesis of insulin, which is used to differentiate diagnosis between the type 1 and type 2 diabetes mellitus. That we discuss later on what is type 1 diabetes mellitus, what is type 2 diabetes mellitus. Type 1 diabetes in which there is a absolute deficiency of the insulin, or there is a destruction of the beta cells of the pancreas. While type 2 diabetes, there is a beta cells, per person have a beta cells, but there is a insulin resistance. Main mechanism of the type 2 diabetes mellitus is the beta cell dysfunction and insulin peripheral insulin resistance. So C peptide level is a indicator for the endogenous insulin synthesis occur or not occur. So function of the insulin, as we previously said, it is a major anabolic hormone. It helps to transmembrane transport of the glucose and amino acid, glycogen formation in liver and muscle, nucleic acid synthesis, protein synthesis. So main function, it is the increased rate of transport of glucose into the muscle cells, heart cells, myocardial cells, fibroblast and the fat cells. Remember, the insulin is not required for the entry of the glucose into the CNS, neural cells. So neurons, entry of glucose into the neuron, which is independent of the insulin. So the function of the insulin is summarized like this way. In fat, it is increased glucose uptake, increased lipogenesis or decreased lipolysis. In muscle, it increased glucose uptake, increased glycogen synthesis and increased protein synthesis. In liver, it decreased gluconeogenesis, increased glycogen synthesis and prevent glycogenolysis and increased lipogenesis. So basically insulin is an anabolic hormone. Now we discuss the pathophysiology of diabetes. So diabetes is a group of metabolic disorder which is characterized by the abnormal metabolism of glucose, which results in a hyperglycemia due to the defects in insulin secretion, insulin action or both. So basically defect in insulin secretion, insulin action or both. So that lead to the metabolic derangement and that result in the hyperglycemia. Diabetes is a serious chronic disease without cure with significant morbidity and mortality. So diabetes is a serious disease. It is also associated with many acute and the chronic complications, and it involves the multiple organ system, mainly it involves the kidney, eyes, nerve, blood vessel. So it is a leading cause of the end stage renal disease and adult onset of the blindness and non-traumatic lower extremity amputation. So due to the blood vessel damage, there is a severe atherosclerosis that lead to the non-traumatic lower extremity amputation due to the diabetes mellitus when the person have a long-standing diabetes. So the word diabetes, which comes from the Greek word siphon and implies that a lot of urine is made, and second term mellitus, which comes also from the Latin word mel, mel, which means honey, and it was used because the urine was so sweet. So that's why the person have the features of the diabetes mellitus like the 3P, polyuria, polydipsia and the polyphagia. So polyuria, so person have the excessive urination. Definition of the diabetes, it is a metabolic disorder of multiple etiology which is characterized by the chronic hyperglycemia with disturbance of carbohydrate, fat and protein metabolism resulting from the defects in the insulin secretion, insulin action or both. So these are the two major classification. Diabetes, it is divided into the two major groups, type 1 and the type 2. Both have the different etiology, both have the different age of onset and the mechanism of action or the pathogenesis of disease, both have the different. Type 1 majority is the genetic basis, autoimmune etiology, it occurs in the childhood, so it is the very early age of onset or the juvenile onset, in which type 1 the antibodies to beta cells of the pancreas that lead to the destruction of the beta cells and the insulitis. There is a inflammation or the lymphocytic infiltration around the beta cells of the Langerhans, that is called the insulitis, that ultimately lead to the beta cell depletion. The person is non-obese, while in contrast type 2 diabetes mellitus, there is some genetic basis but it is different from the type 1. So the type 2, it is not an autoimmune disease. Onset of the disease is in adulthood, so 40 year, 50 year of the age the person starts developing the type 2 diabetes mellitus. Insulin may be low, or the insulin may be normal initially, then after the insulin may be low. But main problem it is the peripheral resistance to insulin is the main factor. While in type 1 there is a destruction of the beta cells, so number of beta cells is less, so no insulin is released. So absolute insulin deficiency, which is a feature of the type 1 diabetes mellitus, while peripheral insulin resistance, which is a main factor for the type 2 diabetes mellitus. And type 2 it is occur in the obese patient, generally occur in the obese patient in obesity due to the excessive lipid deposition that lead to the peripheral resistance of the insulin. So other than the type 1 and type 2 diabetes, there are the other classification or the other subtypes of the diabetes is also there, like the etiological classification of the diabetes, that as we discussed, type 1 diabetes, that is juvenile onset of diabetes, immune mediated or idiopathic. Type 2, non-insulin dependent diabetes mellitus, so it is called the NIDDM, or maturity onset of diabetes mellitus. Other 10% of the causes of the diabetes, or the 10% etiology of the diabetes, which is due to the genetic defect of the beta cell function due to the mutation in various enzymes, earlier called the maturity onset diabetes of young, MODY. So in which there is a defect in the hepatocyte nuclear transcription factor or the glucokinase protein. So this defect, so this mutation in that protein that lead to the defect of the beta cell of function. Another is the genetic defect in the insulin action. So it occur in the type A insulin resistance. Disease of the exocrine pancreas, like the chronic pancreatitis, pancreatic tumor, or post-pancreatectomy, so that also lead to the diabetes mellitus. Endocrinopathy, there is some disorder of the endocrine system like the acromegaly, Cushing syndrome, pheochromocytoma. So other disorders that also have effect on the blood glucose metabolism and that lead to the diabetes mellitus. Drug and chemical induced, so the steroid, thyroid hormone, thiazide, beta blocker, so that also lead to the diabetes. Infection like the congenital rubella infection or the cytomegalovirus infection, so that infection that lead to the destruction of the beta cells of the pancreas. Uncommon form of immune mediated diabetes mellitus and other genetic factor like the Down syndrome, Klinefelter syndrome, and Turner syndrome. And 3 to 4% of the cases it is due to the gestational diabetes mellitus. So the risk factor and the causes of the diabetes that we discussed, the diabetogenic lifestyle plus susceptible genotype. So these two things is important for the person to predispose of the diabetes mellitus. So lifestyle plus genotype. So majority of the cause of the diabetes mellitus in person with the type 2 diabetes is the peripheral insulin resistance, which is attributed to elevated level of the free fatty acid and the pro-inflammatory cytokines in the plasma, so which causes the insulin resistance. Another is the beta cell dysfunction. What is beta cell dysfunction? Beta cell dysfunction means that there is an inadequate insulin released by the pancreatic beta cells. So in response to the stimulus, there is an inadequate insulin secretion by the pancreatic beta cells that lead to the hyperglycemia and the hyperglucagonemia and the consequent hyperglycemia. So the hyperglucagonemia, that means the person have the increased glucagon level, so that lead to the one of the risk factor for the development of the diabetes mellitus. Other risk factors are the obesity, age more than 45 years, family history, so Native American, African American, Asian American, or the Asian African descent people, so that have the more predisposing risk factor for the development of the diabetes. History of the previous impaired glucose tolerance or the impaired fasting glucose. So these two terminology, what is impaired fasting glucose? So the for diagnosis of the diabetes mellitus, that we require the fasting blood glucose level more than or equal to 126 level, 126 milligram. So the impaired fasting glucose, that is the level in between the 110 to 125 milligram per deciliter. So it is called the impaired fasting glucose. So that patient have the more chances to develop the diabetes mellitus in future. Impaired glucose tolerance is the postprandial blood glucose level. So after eating the meal, after the 2 hours of eating the meal, when the blood glucose is tested, then the impaired glucose tolerance, that means that level, if the level is more than 200, that it indicate it comes into the criteria of the diabetes mellitus. But if the level is in between the 140 to 200, then it is called the impaired glucose tolerance. So that that person have the more chances to develop diabetes mellitus in near future. Other risk factor is the hypertension and the dyslipidemia, history of gestational diabetes, polycystic ovarian syndrome. So polycystic ovarian syndrome, that also lead to some hormonal imbalance related to the androgen hormone. It also lead to the diabetes mellitus. Some genetic influence. Now we discuss the pathophysiology of the glucose metabolism and the insulin action. So the normal glucose homeostasis is tightly regulated by the three interrelated processes. Normally glucose level is maintained by these three processes. So the glucose production in the liver, glucose uptake and utilization by the peripheral tissue, mainly the skeletal muscle, and the action of insulin and the counter-regulatory hormone including glucagon on glucose uptake and metabolism. So these three interlinked process that lead to the maintenance of the normal glucose level. Insulin and glucagon have a opposing regulatory effect on the glucose homeostasis. So here we try to understand that during the fasting state, what happens in the fasting state. Low insulin and high glucagon level, it facilitates hepatic gluconeogenesis. So glucose is more and more synthesis occur in the liver and the glycogenolysis. So liver starts the breakdown of the glycogen to glucose to maintain the level of glucose in our body in the fasting state, while decreasing glycogen synthesis, thereby preventing the hypoglycemia. So ultimately role of the liver is to prevent the hypoglycemia. So it starts the breakdown of the glycogen and more glucose synthesis starts in the gluconeogenesis starts in the liver. Thus, fasting plasma glucose level are determined primarily by the hepatic glucose output. So this is important. Whenever we measure the fasting blood glucose level, that is the mainly contributed by the hepatic glucose output. So liver glucose output is by the fasting level. We can check through the fasting level. Following meal, after eating the meal or after 2 hours of the eating meal, insulin level rises and the glucagon level fall in response to the large glucose load. So after eating the meal, our blood glucose level abruptly rises. That lead to the increased level of the insulin, and that insulin promote the glucose uptake and utilization in tissue. The skeletal muscle is the major insulin responsive site for the postprandial glucose utilization, and it is critical for the preventing hyperglycemia and maintaining glucose homeostasis. So after eating the meal, so whatever the blood glucose level, it is the after eating the meal, the skeletal muscle, due to the insulin, that the glucose uptake occur into the skeletal muscle. So intracellular transport of glucose, it is mediated by the GLUT2. It is an insulin independent glucose transporter in the beta cells. So glucose undergoes oxidative metabolism in the beta cells to yield ATP. ATP inhibits the inward rectifying potassium channel receptor on the beta cell surface, and the receptor itself is a dimeric complex of the sulfonylurea receptor and potassium channel protein. So inhibition of this receptor, that lead to the membrane depolarization and the influx of the calcium ion that release the stored insulin from the beta cell. So this mechanism explain how the glucose enter into the beta cells of the pancreas and the start synthesis of the insulin and release of the insulin through the glucose through the various receptor. The sulfonylurea class of oral hypoglycemic agent binds to the SUR1 receptor protein. So this diagram explains in the left side it is the beta cells of the pancreas and right side it is the target cell. In the left side it is the pathway of normal insulin synthesis and release in beta cells of pancreatic islet cells. So in the right side the events in action of insulin of target cell. So insulin on target cell, protein synthesis, glycogen synthesis, lipogenesis, glucose transport, and the various mitogenic action. For the insulin, there is a receptor. It is called the IRS1, insulin receptor substrate molecule 1, 2, 3, 4, which plays central role in insulin signaling and maintenance of basic cellular function like the growth, survival, and metabolism. So IRS1, the location is different, which is glucose production in skeletal muscle. IRS3, 4, it is a central role in insulin signaling. IRS1 defect result in the type 2 diabetes mellitus. So this diagram explains how the various insulin receptor substrate molecule 1, 2, 3, 4 present inside the cytoplasm. So the insulin which is enter, that leads to the 1, 2, 3, 4, and the further the MAP kinase pathway activated, or the PIK3CA that activated, that led to the increased glycogen, lipid and protein synthesis, decreased lipolysis, cell growth and differentiation. So this GLUT4, which is also a receptor, acts against the glucose. So for the entry of the glucose inside the cell. So as we previously discussed, insulin is a potent anabolic hormone with multiple synthetic action. So the anabolic effect of the insulin, which are attributed to increased synthesis and reduced degradation of the glycogen, lipid and the protein in our body. So it is a major anabolic hormone, and insulin also has the several mitogenic function, which include the initiation of the DNA synthesis in certain cells and the stimulation of their growth and differentiation. So this diagram also explains the insulin action, that the lipogenesis, increased glucose uptake, glycogen synthesis and protein synthesis in muscle, lipogenesis, decreased lipolysis in adipose tissue, and in liver it causes the increased glycogen synthesis and the increased lipogenesis. So during and immediately after the meal, digestion breaks carbohydrate down into the sugar molecule, of which glucose is one and protein into amino acid. So after eating the meal, glucose and amino acid are absorbed directly into the bloodstream and blood glucose level rise sharply. So the rise in blood glucose level signals beta cells in pancreas to secrete the insulin, which pour into the bloodstream, and then within 20 minutes after a meal, insulin rises to its peak level. So insulin enables glucose to enter the cells in the body, particularly muscle and liver cells. Insulin and other hormones direct whether the glucose will be burned for energy or stored for the future use. So that insulin will decide that our body we have requirement for the glucose for energy, or the storage for the future use. When the insulin level are high, the liver stops producing glucose and stores it in other form until the body needs it again. So liver acts as a mainly storage function. So this is the similarly protein synthesis, fat stimulate the lipogenesis. So this diagram also explains the pathogenesis involved in the type 1 and the type 2 diabetes mellitus. In the type 1, there is a genetic susceptibility. So concordance in identical twin, it is the 50% susceptible gene on HLA region in chromosome 6, that some environmental factor like some viral infection, experimental induction with chemicals, geographic and seasonal variation, that and plus some autoimmune factors, some islet cell antibody, insulitis and CD8 positive T lymphocyte mediated selective destruction of the beta cells. This environmental plus autoimmune plus genetic susceptibility all together, that lead to the development of the type 1 diabetes mellitus, which is called the juvenile onset of diabetes mellitus and the insulin dependent type of the diabetes mellitus. While in type 2 diabetes, there is some role of the genetic factors. The concordance in identical twins is 80%. Both parents diabetic, there is a 50% risk to the child. Plus, there is some constitutional risk factor like the obesity, hypertension, low physical activity, sedentary lifestyle, and that lead to the decreased insulin secretion. So these all features, obesity, hypertension, low physical activity, that all lead to the decreased insulin secretion, amylin, glucose toxicity of islet and the lipotoxicity, that lead to the insulin resistance, receptor and post-receptor defect and the impaired glucose utilization. So that lead to the increased hepatic glucose synthesis and hyperglycemia. So hepatic glucose output is increased, that lead to the hyperglycemia and type 2 diabetes mellitus. So these are the list of the symptoms that we discuss in the next lecture. That is the major symptoms of the diabetes. It is the polyuria, polydipsia, polyphagia, weight loss, and the fatigue. So here this diagram also explains the insulin deficiency and insulin resistance that lead to the why the polyuria occur, why polyphagia occur, or the polydipsia occur. So there is an insulin deficiency that lead to the decreased tissue glucose utilization, and that glucose spill over into the blood. So the blood level of the glucose is sharply rise. It is called as the hyperglycemia. So hyperglycemic blood which enter into the kidney or the which enter into the liver, that lead to the polyuria, then polyuria that further lead to the volume depletion and the polydipsia. So the glucose hyperglycemic blood that filter into the kidney, that causes the glycosuria. So the urine contain the glucose, so that lead to the polyuria and the further the increased thirst, that is called the polydipsia. Sometimes there is a excess of glucagon that lead to the gluconeogenesis. Is more and more gluconeogenesis starts, that in the ketoneogenesis. So the ketone body is secreted into the blood mainly, that lead to the ketoacidosis, and the ketone body which is goes into the blood and the further into the kidney, that lead to the ketonuria. So ketone product in the urine which that we detected. So it is the ketonuria that is a indication for the person of the diabetic coma or ketotic coma, diabetic ketotic coma. Action of the insulin deficiency on muscle, that lead to the increased protein catabolism and amino acid. So there is a increased destruction of the protein and release of the amino acid, that lead to the polyphagia or the weight loss. And similarly in adipose tissue there is increased lipolysis and the increased destruction of the protein, that both lead to the polyphagia, and the polyphagia that again hints towards the gluconeogenesis. So this vicious cycle starts, and the ultimately the death of the patient occur in the complication of diabetes. The lethal complication of the diabetes is the diabetic coma. So this cover the brief about the diabetes mellitus, types of the diabetes mellitus, pathophysiology, action of the insulin, and the next lecture that we discuss about the pathogenesis of the type 1 and type 2 diabetes, clinical feature, diagnosis, and the complication. Thank you.